Okay, good evening. Welcome to 2021 Virtual Tumor Board. I wish everybody on call a very happy new year. I know it's been a challenging year the past year, but hopefully this year will be better. We have our first session of the new year, which is dedicated to hypopharyngeal carcinoma. We have an excellent panel today. Dr. Riz Aslam from Tulane University will be the co-host, and myself, Bob Akivi from NYU, Jeff Liu, and Michael Moore are here for the support. We also have a special guest, Dr. Kendra Harris from Tulane, who is one of the radiation oncologists, will give us the radiation perspective. I see Dr. Sharif Jalisi and Dr. Yash Patil also online. Looking forward to have a very productive conversation. It's 7:03 Eastern Standard Time. It's 37 degrees here in New York City. I'm sure you guys are having warmer, except for Sharif, it's probably freezing out there. All right, Riz, you want to start?
Yes, good evening. Thank you for that introduction, Babak. And I'm going to be presenting the first case of hypopharyngeal carcinoma. So initially, a delightful 61-year-old white male presented to me with a history of odynophagia. He was seen by an outside otolaryngologist and was noted on assessment to have a lesion involving the posterior pharyngeal wall. He was tolerating PL okay. He had some odynophagia, no stridor, no respiratory distress. Otherwise, had these symptoms probably for more than 1 month, but pertinent to his history is a history of gastric CA, which was treated 2 years prior with a partial gastrectomy, adjuvant chemoradiation therapy, and has an indwelling G-tube. So he's getting some nutrition. Body habitus is otherwise a pretty healthy guy. His medical history is otherwise insignificant. He does have a history of 1.5 packs per day in terms of tobacco use, and is a prior drinker.
I assume you scoped him. What did you see?
Yeah, so on scope, you did notice that there was an exophytic appearing lesion involving the posterior pharyngeal wall. It was kind of difficult to ascertain where it kind of ended, and looked like it extended to the level of the arytenoids, primarily involving, like I said, the posterior pharyngeal wall. Did not encroach the lateral pharyngeal walls.
Do you have an image, clinical image of your scope? I think Riz is...
That's kind of what we're dealing with.
Okay. Riz, sorry, we lost you for a minute. Do you have a clinical picture of your scope? Going in and out. Okay, let me ask Yash. Yash, what's your routine when you see somebody like this? Would you go to CT first? Would you try to do in-office biopsy? You take to the EUA? How do you approach this? Are you on mute?
Yeah, I'm sorry.
Okay.
Generally, when I'm in the office, I try to get as much done as I can. Typically in a patient like this, I'm going to take them to the OR and do a quad scope and examine the extent of the lesion. So I wouldn't necessarily FNA the patient if there was cervical lymphadenopathy, but I would scope or strobe them, and I would also assess their swallowing function with a speech language pathologist. I just try to get as much done the first day as I can. You know.
Sure. Would you routinely get them a CT imaging when they show up before you take them to the office, the OR?
I'm okay before or after, and the patients had no prior history of, I assume the gastric cancer was abdominal, all treated outside the head and neck. I see no reason why CT neck and chest wouldn't be fine, but honestly, in a patient with 2 malignancies, I think I would tend to favor a CT PET. If it didn't give me the resolution I wanted, just at the primary site, I could also add a CT neck with contrast, but I would be nervous in a patient with 2 malignancies, one of them very aggressive, 2 of them very aggressive, to just get localized or CT neck and chest. I'd be a little nervous.
Yeah. I think that's very reasonable. Okay.
With gastric cancer, it's going to change what you do.
Yeah. All right. Riz?
Yep.
Looks
So
like you were coming in and out, so just make sure that we have a good. All right. So I guess most of us would agree with imaging and probably EUA.
yeah, so we did exactly that, Babak. CT scan here. I just have some slices, some pertinent slices from the CT scan itself. CT scan with contrast kind of demonstrates this lesion here in the submucosal posterior pharyngeal wall. Can't really delineate it between the prevertebral fascia or the spine per se, but he kind of has, you can see a nice plane here, and there's somewhat of a plane around there. But that's all really, that was the best cut on the CT scan that kind of shows this area. And it's very subtle. Definitely if radiologists maybe hadn't had the history, they may not even pick this up. So again, I think it's important for us to always remind ourselves to look at our own imaging and kind of combine what we find clinically as well with our radiographic studies.
Okay.
So there was no obvious cervical lymphadenopathy, no other adverse features on the CT scan. So we took him for the EUA. Direct laryngoscopy kind of demonstrated this exophytic lesion arising in the posterior pharyngeal wall. You can see some blood there from the suctioning. It did extend to the level of the arytenoids, the junction of the pharyngoesophageal junction. When you did with performing laryngoscopy.
You're breaking up again.
Bob, one quick point, and this is probably obvious to many on the call, but just to reiterate it, the assessment of resectability really can be established in the office, with rocking the larynx back and forth. That's very much in the mid neck, so you're not going to be tethered down low or up high, just by anatomic constraints. So you could get a very good sense of the prevertebral fascia.
So I'm glad that Riz has given us a very rare case. So Sharuf, what would you do? I assume that this is a squam.
Can anybody hear me?
Yeah.
Riz is back.
Okay, yeah. I'm sorry about that. Long story short is I felt the lesion based on what I could see and circumferentially around the tumor, there was clean mucosal edges. And to Mike's point, I thought it was a favorable in terms of resection. But nevertheless, it did extend to the pharyngoesophageal junction, so that inferior margin was a little bit concerning to me.
Okay, so let me ask Shahrukh. So you have a posterior pharyngeal wall. The patient had partial gastrectomy. You just squam. Look like it's not very deep. What would you do, Shahrukh?
So I think the important thing, can you go back to that picture, Riz? So I think the important thing here is part of your endoscopy, which I think is a very important thing, is to see a couple of things. Number one, what is the lower extent of this tumor? Is it shooting down the esophagus or not? So I'm assuming, Riz, you did a esophagoscopy or some way to evaluate the at least upper esophagus. And second is, I think Michael alluded to it, is to see the mobility of the prevertebral. So I actually palpate this with a whistle tip suction to make sure this is mobile on the prevertebral fascia. So those are two things I do. So let's assume, I don't know, Riz, do we have any more information on how low this is going?
Yeah, again, so you were able to elevate with the laryngoscope and you were able to see the distal margin of this tumor. It just extends very subtly into the pharyngoesophageal junction. So you can see the distal aspect of the tumor very clearly.
Okay. And I know we saw this. Go ahead.
You mentioned arytenoid. This is posterior pharyngeal wall. Arytenoids are kind of anterior.
Yes.
Circumference all the piriform sinus and come forward? How does it
No. I was giving the arytenoids as a level. So
I see.
Tending to the level.
Okay.
Yeah.
Got it.
Yeah. Exclusively isolated posterior pharyngeal wall.
Okay.
So Riz, at least on this picture, it looks like this is one subsite of the hypopharynx. I'm assuming
Correct.
the piriform sinuses are clear, and the arytenoids are clear, and the postcricoid is clear. Seems like, what do you have, a T1, and the vocal cords are fine, T1 and 0. So I think you have several options for this this patient. Obviously, I always give the patients three options. One is they have the choice of doing nothing. They can choose to do nothing. Tumor will grow. Ultimately, they'll die. Second is he could go for chemoradiation. Obviously, I think the location is such that you'll probably get you'll get dysphagia with narrowing of your esophageal sphincter. And then the third is a resection. And, if it's that localized, I guess you could try an endoscopic approach with laser or something like that, and try to get this out completely, at least for the primary, and then see if you need to address the next. I would still go ahead and address the next. Otherwise, obviously, the tested situation in this poor guy's for surgery would be total laryngopharyngectomy and a free flap. I wonder if you could just do a posterior pharyngeal wall resection, but in my hands, you tend to bag the recurrent laryngeal nerves and then get a big problem. So I would favor either, if you can do an endoscopic approach, that'd be great. If you really want to make it safe, then do a complete resection with a laryngopharyngectomy. Otherwise, you can go for non-surgical treatment.
Sure. Okay, so since we have an expert, let's ask Dr. Harris. Dr. Harris, what would be your recommendation, and what's the experience of radiating posterior pharyngeal wall for a T1/T2 tumor?
Yeah, I guess a couple of comments. First is, in most of the aerodigestive subsites, stage 1 and stage 2 can be treated definitively with radiotherapy alone, which helps in terms of an incremental reduction of toxicity. My experience with the hypopharynx in this location is taking 70 gray to the superior aspect of the esophageal inlet is something that you don't do when you have other options. The intermediate term risk for esophageal stricture in this location is really high. So if I had a surgeon that I trusted who felt that there was a reasonable chance of having a margin negative resection safely, this tumor doesn't have any other known adverse risk factors and makes them a candidate for observation. If you're going to end up doing a total pharyngeal laryngectomy, that competes with the toxicity of having a stricture at the esophageal inlet. You could do primary radiotherapy, understanding that stricture is the primary life-altering toxicity that you want to try to avoid.
Absolutely. So,
Dr. Harris, can you comment on your fields of radiation for the lymph node basins? Besides, would you do bilateral next 2, 3, 4? What about the central compartment when you do your planning?
Yeah, it's a good question. So when we're doing radiation planning for hypopharynx, we think of them as a very precocious nodal distributor. So that's the other issue here, is that if you're going to do primary radiotherapy, you're really committing to bilateral neck coverage. You also need to think about the low central neck, even below the suprasternal notch. Most radiation oncologists, given clinical node negativity, if they're doing definitive radiotherapy upfront, would segment between high-risk nodal regions, which would receive an intermediate dose, and so-called low-risk nodal regions. But you really do have RP nodal risk theoretically all the way down to below the level of the of the sternal notch. So it's not an easy course, even without chemotherapy on board, which is why if you're in a circumstance where you think you can achieve adequate negative margins, it's certainly worth seriously looking at.
So I guess Yash kind of read my mind. This is so Shahrukh mentioned that he would address the neck if he goes to surgically, and we'll kind of talk about it. But what about, this is the prime location for retropharyngeal nodes, and retropharyngeal nodes surgically, although we can, it's not the easiest thing when you have an intact larynx to do it completely. So Shahrukh, what's your approach if you are, and I assume you're advocating bilateral neck, what would you do for retropharyngeal nodes if you go surgical route?
So, Babak, we know the approach to the retropharynx in this area with the spine approaches that we do. So I think as long as you can find the carotid, medialize it, I'll clean out level 2, 3, and 4, and then get behind the larynx and take the lymph nodes out. The only thing would be the neck dissection will probably be, if you're doing this endoscopically and you can get it out, I would do it in a staged manner, because otherwise as soon as you lift up the pharynx, you'll have a fistula. So I give it a couple of 2 or 3 weeks for things to settle down, to allow things to heal down, and then you can come up and then you can clean that area out. But you can lift these things up. The key thing is a medialization of the or lateralization of the carotid, so you can go medial to it and then clean out that area, and then go from there. But you're right. I mean, you have to counsel the patient appropriately. You can get recurrent nerve injuries in that move. You can have spasm of the carotid, especially with the older patient. So you have to think about this.
Okay, so let's see, Yash, what would you recommend for this case?
The only thing, and I just want to back up again, the only thing that really bothers me is this patient has a G-tube, and we did not assess their swallowing function. And I just want to be entirely honest, if the patient has poor swallowing function for whatever reason, or they have active gastric cancer, I mean, I would just back up a little bit and just make sure that the patient swallows really well. They have a G-tube maybe because their remaining stomach is very small and they supplement. I would just clarify all those details. And then anytime I do a case like this, an endoscopic, minimally invasive case, whatever, I always try to stage things. And I will pick the thing that I think is going to go the worst. So if I resect the posterior, in this one, obviously the posterior pharyngeal wall from the scans that we have is going to be the worst. And if I resect that and it goes poorly, I stop and radiate.
Sure. Okay, so we have 3 minutes. Let's have Riv to tell us what he decided and how it ended up.
Okay. So, of course, I had to throw a wrinkle in here, right? That's going to be that straightforward, right? Yeah. So the wrinkle is the guy's pretty upset and says, "Doc, you're not cutting my neck. We all have the patient. I don't want you to touch my neck with a knife. I've had gastrectomy. I'm done. I don't want any, I don't want you to make any incisions on the outside of my neck." Right? Okay. And okay, well, sir, do you want non-surgical management? I don't want that radiation and I don't want chemotherapy. No way. I had that too. That stuff's terrible. I'm not doing it. So that kind of put me in a corner when obviously then I said, look, the only thing I can offer is trying to get control of the primary site. You run the risk of metastatic disease to your neck, which may be occult. We didn't have any evidence on our imaging study. I did get a PET that just showed the primary site. You can see here, there was no evidence of nodal disease, no distant spread. The stomach was fine. So we went ahead and proceeded with a transoral robotic approach to this. And you can see here kind of the extent of the tumor. I'm using a laser tube, all right? I'm just kind of in this video here just showing the extent of the tumor. It was a little tight, a little tricky, but I felt for him that since I couldn't make any external incisions, this was my best and probably my only approach that I could get this tumor out. Here you could see, again, I was using the CO2 laser.
What kind of retractor do you have in the mouth?
This retractor, I was just using actually a Crow Davis, which I tend to use a lot for my torus cases. So you can see here, this is the OmniGuide hand device. I love this instrument. I think for these narrow margins, it gets you a tighter margin. It's not.
Oh, breaking up again. What's going on with the bandwidth?
He needs to upgrade his.
I think there's something going on with there.
He's driving in the car.
For sake of time.
All right.
Okay. So I assume you got negative margins. Now let's say we get negative margin, and this is T1 or T2.
I don't know. Can you guys see this?
Yeah, we can, but I think you don't have enough bandwidth for all the videos.
It's frozen.
Yeah. If you just stop the video and just tell us how it ended.
Yeah. So here you can see this is the ablative site. All right. Negative margins there with the inferior margin, as expected, was close. It was a 1 millimeter margin on the distal aspect. So he did find from the surgery, he did have some postoperative dysphagia that resolved with time. You can see here again the postoperative ablative defect.
Yeah.
And it ended up being actually 2.3 centimeter moderately differentiated squamous cell carcinoma, no PNI, no LVI, 1.5 millimeters from the inferior margin.
Okay. So what next? Dr. Harris, would you radiate? Or the neck? Just not the pharynx, just the neck.
Yeah, so I think it's reasonable to note that negative margins are typically more than that. It's also true that the tumor was larger, but doesn't have any of the other true risk factors, which Dr. Aslam mentioned, of perineural invasion, lymphovascular invasion. This is an area of some controversy among radiation oncologists. I tend to never offer radiation to one or the other. That is, I have worked with head and neck radiation oncologists who I respect greatly, who do occasionally offer radiation management of the neck, leaving the primary alone, or radiation management of the primary postoperatively if the necks are negative. I'm not among them. So have a long discussion with this patient about what is a black hole in terms of our data. The post-op meta-analysis suggests that this patient needs chemo-RT, but if treated in the primary setting with intact tumor, would have gotten radiation alone. So it would depend heavily on the patient's preferences. In general, I think the risk of an inferior recurrence is high, and that's a terrible place to recur.
In the interest of time.
What's that?
I think if you take the tumor, in the interest of time, I'm just going to ask you to call it a ball or a strike, radiate or not. What would be your recommendation?
Young, healthy man, 1.5 millimeter margin. I'd recommend postoperative radiation alone.
Right. And would you cover the neck too?
I would.
Okay. All right. Radiation alone. Okay. Well, I think that's very reasonable. And so the question from the audience is for Riz and also for Yash and Shahrukh, would you consider re-excision with that 1.5 millimeter margin? It's going to be hard. It's going to be lower, correct? Really low.
It was hard. So I did go back in and I re-excised an additional margin from the inferior aspect.
And that was negative.
It was negative.
Yeah, it's almost always negative. Okay. What did you decide? Let's just move on fast.
Sorry, what was that?
What did you decide? How did you end up?
That was it. The patient refrained from any further treatment, and that was the end of it.
Okay. And how long of a follow-up do you have for this guy?
So unfortunately, he was found to have lung mets and mediastinal nodes, and eventually succumbed to his disease. So
was it the lung mets from this or from the gastric?
It was hard to say. We couldn't really, find out much more beyond that. He went to another hospital, lost out to an outside facility.
Okay. Thank you.
Hey, Bob.
Right, so, yeah, go ahead.
I just want to very quickly in 20 seconds for the trainees, certainly narrow field radiation for early glottic cancer is something that I bet we would all agree is reasonable. And then anytime you're thinking about endoscopic resection, when you take that patient for your initial EUA, your quad scope, you better put the instruments in until you get a lot of experience so you know you can expose the tumor. That's it.
Yes, 100%. That's the best. That's a great point. So, okay, we're going to finish this, but as you all noticed on the call, it's a 1.5 centimeter small, not very deep, but it is a really bad player. Even with good surgery, even everything else, these patients unfortunately don't have very good outcome. And it's not because of us, it's just a bad disease. And I agree with Dr. Harris that these are the ones that you have to take very seriously. And personally, if this patient would have, even if I had complete negative margin and I didn't want to radiate his pharynx 270 gray or something, I would prophylactically radiate the neck after my surgery. And I think that's very reasonable. You cannot ignore the risk of lymph node metastasis for these patients. All right, who's next? Is it Shahrukh or Yash?
Either one's fine.
Shahrukh, I think, is next. That's
Okay.
the kind of order that we had planned it in.
Okay.
If that's okay, Yash.
Right.
Keeps me from getting dinner.
You're not intermittent fasting?
Yeah, right. Looks like it. I have Spanx on.
Okay. Shahrukh, you're mute.
1 second, let me get this PowerPoint.
Okay. Mike or Jeff, any comment for the last case?
Yeah, just a quick comment that, I know a patient selection, patient preference. had a big role in the sort of ultimate patient decision, in the clinical decision making. But as a strategy for an early stage hypopharyngeal cancer, I would try to lean toward a single modality, either one way or another. So either surgical resection with bilateral neck dissection, or primary radiation therapy to the primary site and the at-risk lymph nodes. Just as a general strategy, I think when you mix strategies, like I'm going to cut out the primary and hand off the nodes to the radiation oncologist, I think we try to favor a single modality treatment for those individuals. It decreases the package time and it makes it more straightforward. So just something to think about.
Yeah, I agree. I think that's a very pertinent comment.
But this case had some.
Yeah, this was a hard one. And I'm glad that we are actually presenting these hard cases. Okay,
right.
Let's go.
Can you guys see my screen?
Yeah.
All right, perfect. All righty. So this is a story of a 72-year-old male with a 6-month history of a right neck mass. He presented with dysphagia with the neck mass. No weight loss, interestingly, but as you guys can see, he's got a pretty extensive alcohol abuse history, smoking history. He had alcoholic hepatitis coming in. He's got COPD, diabetes, hypothyroid, a bunch of medications, and so on and so forth.
Basically, a Jalicia special.
It's my special, yeah. I attract these people from all over the place, so nothing can be straightforward. High case mix index.
All right.
So anyway, so we examine him. He's got, pretty much everything's okay. He had a 3x3 centimeter neck mass on the right side. I wrote mobile, but not that greatly mobile. It's kind of sort of on the fixed side. His right vocal cord was immobile on the fiber optic, and I saw there was mucus in the hypopharyngeal inlet. Otherwise, the rest of his exam was fine. So, any thoughts? So
I think I'm glad that you actually brought that point and you mentioned that this is an experience that I had. A lot of time when you have a patient with hypopharynx, your exam in the office is not going to be good because they have a lot of pooling of secretion, and that can fool you, and it definitely has fooled me in the past. So try to spend some time and see if you can do some maneuver to clear it. If not, don't think there's nothing there. There's usually something down there that's causing that. I think in the interest of time, because you lost 5 minutes, I'm just going to go quickly. Riz, what would you do next?
Sorry, Babak, I had trouble with my internet again. I'm now on my third Wi-Fi. So let's see here. If you could just go back one slide.
I'm giving you the answer, Riz.
I missed your initial slide because my silly internet.
That's fine.
72-year-old male.
Let me ask Yash for now.
Yeah.
Yash, would you do imaging?
Yeah, I try to get everything done in the office. I would FNA the neck mass and schedule him for quad scope and get scans.
Okay. All right.
That's what we did. We got scans on him. He got a CT neck. We don't do fused PET CT scans. I don't know if you guys have that in your hospital. So that's why we got to get a diagnostic CT and a PET scan. The PET scan did show some uptake in the chest. So that's why he got a chest CT for our thoracic guy. So he had some mediastinal nodes. But the thoracic guys didn't think it was anything. But basically this showed cortical destruction. Here's a CT scan starting from the top left. You can see this tumor sort of more towards the left side. But when we did the endoscopy, that's why I think endoscopy becomes important to see where this is going. He had this lymph node on the right side, level 3. This is what I was feeling in the clinic. And then there are these 2 mediastinal nodes right here for which he ended up needing the CT scan, which again, our thoracic buddies felt didn't require anything and that we could consider him a M0 at this point in time. This is a PET scan, really lit up like a Christmas tree. It was going out into his strap muscles, and we staged him as a T4A, N2B, M0 squamous cell carcinoma after the biopsy.
Goes through the strap muscles?
It goes into the strap muscles pretty well. Here's the intra-op view that I just want to show you guys, that most of this tumor was actually, despite all the PET and everything, was on the post-cricoid mucosa, right behind the arytenoids. And then I think actually, Jeff, you managed one of my patients who moved to Philadelphia at one point, who had a similar darn tumor. And this was just stuck behind it, going over along it. The posterior pharyngeal wall is completely clear that you can see on this endoscopy. So this is opposite to what Riz described, posterior pharyngeal wall versus the post-cricoid mucosa, and this was all squamous cell. So any thoughts?
Okay. All right, so big tumor, big neck, thick guy. How's his heart, by the way? And you will see why
his heart was fine, but he has COPD. You know, he's able to walk probably a block or so without getting short of breath.
So Dr. Harris, we have a bunch of bloodthirsty surgeons here. Would you be able to save this patient from us?
Oh, take him away, friends. Take him away. No, I mean,
We go single modality.
yeah, this patient needs a swallow study TL.
Yeah.
Yeah. We never should
primary. One comment I make is at NYU, we routinely check all upper airway digestive tract for P16 and HPV, although that doesn't mean for hypopharynx that's relevant or should change your management, and especially not for this. But I would want to put a peg that there are more and more papers that are coming that a minority of other tumors that oropharynx could be HPV positive. In some aspect, that could have a difference. Obviously, this is not a case for non-surgical management because it's clearly T4A. And the reason I asked for it is heart function because remember, all the evidence that we have is concurrent chemoradiation is with platinum-based agents. And if that's with cisplatin, we rarely have any randomized trial with carboplatin. And cisplatin with a sick guy with a heart is not going to happen. So that's another factor that is probably moving more towards surgical.
I just want to
Yash, what would you do?
Well, the one thing you have to assess carefully is the inferior extent.
Okay, maybe it's just like a little.
You need to assess the.
If you please mute your microphone, thank you.
You need to assess the inferior extent. And Babak, I think you mentioned a peg tube, and I wouldn't peg them until you decide on the recon, because if it goes low and you got to do a gastric pull-up or something, you're gonna hate yourself for that peg.
Okay, let's see. Let me ask Mike Moore.
Yeah, so I would recommend obviously surgery. I think a couple of things in the planning. So I look at the sagittal on the imaging to see how low it goes. In addition to the endoscopy, you can get a good look on how far it goes down. These post-cricoid ones, you run out of mucosa in a hurry. So you almost want to plan for a circumferential repair, even if it looks to all the world like the posterior wall is okay. Any sort of margin, you're going to almost certainly be circumferential, or at the most leave a little kind of mucosal strip that's not worth a whole lot. So yeah, I would plan for a circumferential repair.
Yeah, I agree with you. And I see Dr. Weed is also in the background. So Don, please join if you would like many comments. I think that's what Shahrukh said in the exam. You don't exam to diagnose disease. The exam under anesthesia is really a staging. And you have to be, and preparation for final plan. So it's not just you take the patient to the OR and just put the scope in and take a biopsy. You really want to know where the tumor starts, where the tumor stops, and get a sense for yourself and for your reconstructive surgeon if you're asking somebody else what is involved. I think everybody agrees that T4A advanced disease is a clear indication for primary surgical treatment. So, but the surgical treatment is going to be tricky because
That's awesome. So I always tell people, you got to give people all the three choices. So this guy said, as it happened with Riz, I don't want my surgery. So I was like, okay, he had a baseline swallow evaluation which showed aspiration. So he's already aspirating, right vocal cord is out, tumor's out in the strap muscles. You know how the story goes.
Please tell me no one radiated him.
Well, he got radiation. It was opposite to him. He opted for primary chemoradiation, and then he comes back for PET scan 3 months post-treatment.
Oh yeah.
So it's kind of interesting that he got a pretty significant improvement, I could say, but you can see there's still persistent disease. The guy was PEG tube dependent. He actually came in shortly after his PET scan with emergently to the ER with respiratory distress. He got an emergency trach. He got an endoscopy, showed residual tumor in the post-cricoid area, and this time it was extending into the lateral wall of the piriform sinus. His entire upper esophageal sphincter was scarred over, and we couldn't even get a scope in at this point in time. For some reason, he had pulled out his PEG tube, so that was replaced. And by now, his CT chest is showing multiple lower lobe nodules. And this is literally within 3 months of him finishing his primary treatment. So any thoughts? What we gonna do? next or options, guys?
Okay, so also we have a great question from the audience, and I put it to the experts. This is an excellent question. Let's say this guy has already had an EUA, a biopsy, and then come to you, and you decide to do surgery. Would you take him back to the OR to see for yourself how big the tumor is before you decide or not?
Absolutely.
Yes, 100%.
Exactly. I was going to
No
say.
question.
100%.
So
Yeah.
for
I
the
think,
audience,
I
don't
think
be
from a-
worried about taking the patient back to the OR.
Yeah,
Go
I
ahead,
think, you know, if you're going to be the primary treating surgeon for a patient, I think assessing resectability up front is really important. And I think having, you know, you don't want to go to the thing like, hey, I'm going to take a look, put you to sleep, and if it looks good, I'm going to take out your larynx and you're going to wake up either, you know, an hour from now or 8 hours from now with a free flap.
Yeah.
So I think it's really important to be able to have really good assessment of the tumor and know what you can offer the patient. And so I absolutely would plan for, you know, a DL and careful examination and really size up, you know, because it's also going to size up your recon. It's not just for how low the resection is, but whether you need a gastric pull-up versus, we get away with the tube with flat. So I think these things are really important if you're going to be the primary treating surgeon to bring the patient back. I think, and that's true for this case. That's true for oral cavity where they have trismus and you can't see the posterior extent. No one is happy when you start your resection and you get totally burned because you didn't do a good examination or you couldn't in the office. So I highly encourage to always take a patient to the OR if you're in doubt.
Now, so there's another excellent question from the audience. This is for Riz. So Riz, question is, this patient comes in, now it's failed, the PET is positive, and there are some nodules in the lung. Would you go after those before you offer definitive treatment, or you say, you know what, it just needs to come out? What's your re-staging? If you have any suspicious signs?
Yeah, I mean, if I have suspicious nodules in the lung, I'm definitely going to work those up. I mean, I think that a guy with this advanced kind of disease, and now he presents you with potential salvage surgery, but has evidence thereof of distant mets, I think you're obligated to work those up, in my opinion.
Yeah, I agree with you. Okay.
Okay, so options at this point in time, obviously, Riz, you said the right thing. Let's work up the lung nodules. But, you know, the question that was posed to us was, can we do curative intent surgery on this guy? The other choice obviously was, should he go for palliative chemo, and nowadays obviously immunotherapy. So that's what really the crux of this little discussion is what are the immunotherapy studies out there? And the other one, DNR, DNI, hospice care. So for the fellows, I don't know if you guys learned this, I do DNR, DNI end of life discussion in my office as a surgeon. We'll go through this, we'll have them sign the forms that they need to, and then clarify the code status. So that I think that's a significant part of this patient discussion in my office is to see what do they really want to get out of life. We have a palliative care team that works with us very closely, but I have no qualms in having this discussion, signing the forms myself with the patient and the family. So I think don't be shy, because these are patients who are going to get sick. They're going to have bad outcomes. And you as a surgeon can really make a difference in which way this person is going. I've seen too many people piddle around in the hospital getting one thing or the other, and nobody's talking about the code status or telling them, guys, you have an incurable condition.
Okay, so guys, for the trainees, when would we resect a metastatic patient?
Okay. Well, you know, the trainees here are protected population, so you have to answer your question yourself.
Sure. If someone has a non-functional larynx and very minimal metastasis and good function, I would resect them for squamous cell.
The other thing we also do is, besides that, is if it's a resectable lung nodule that our thoracic guys feel they can take out with adequate margins, then we will offer up top surgery in the larynx and pharynx, and then they will follow up a few weeks later for the lung resection. But that's really the only scenario, but patient has to still be in a reasonable condition. Now, one thing I didn't talk about this guy continued to smoke and drink through all this, which is kind of amazing, till the esophagus shut down and scarred over. So it's kind of amazing that this guy was able to get alcohol in him. But anyway.
So I'll tell you what I would do. I would probably I try to send them up to you. I guess. But you know, what I always say is, let's go by the guideline. The guideline says if this patient still have potentially curable disease, just to keep it simple, we can offer surgery, but I don't think any of us have any qualms about how wonderful it's going to be. Riz, what would you do? Would you offer surgery?
I think the surgery in this particular circumstance is not the surgery where it's just a salvage laryngectomy and primary closure. I mean, the surgery in this circumstance is going to be some part, maybe a cervical esophagectomy included in this. So this is a big surgery and a previously full course radiation definitive management. I think that you're looking at significant risk of complications in this patient. I think if you have a patient that was weary of surgery the first time around, I don't think that they're going to be necessarily interested in this. So, I mean, I would offer it, but with the caveat being that there's potential morbidity associated with it that they may not ultimately be.
Let me ask Don. Don has seen, I'm sure, a few of these through the years. Don, what would be your philosophy and the Miami philosophy in approaching these patients?
You know, I would comment on two things. One that I know Shahrukh did, but just from the perspective of the trainees, we presented two patients where the patients dictated their care. And in this case, the patient clearly dictated not his best choice. You owe it to your patient to not let a busy clinic prevent you from spending a significant amount of time trying to educate the patient and convince him of what really is his better option and to proceed with surgery. That said, now that you're in this position, I would also say that not everything that walks like a duck and quacks like a duck is a duck. And this patient is at high risk of aspiration. Those lung nodules absolutely could be inflammatory. And I wouldn't write him off without working that up, because he absolutely could have aspiration changes and a bronch or CT guided biopsy that is negative would push me for total laryngopharyngectomy, free flap or salvage. But again, if the patient was unwilling to do that to begin with, part of my conversation with him prior to his choosing radiation would have been, you're really not going to want to do the operation that I'm going to offer you when it's your only option for salvage. And that's exactly the scenario that you said now.
Exactly. All right. In the interest of time, Shahrukh, let's just finish this in 1 minute.
Yeah. So just quick things for the trainees. I think this is a really good review article you guys should get off the JNCCN on the pretty much a review of immunotherapy that's available out there. The three major trials that have happened, Keynote 12, again, remember this is all with tumors that have PD-L1 expression. They got pembrolizumab, overall response rate of 18% with a complete response of 4%, but only a median progression-free survival of 2 months. So you want to put this in your discussion with these patients as they start going on to these immunotherapy trials. Another one, Keynote 55, where again, a progression-free survival of 2 months. And then a Checkmate 141 that we hear a lot about, phase 3 randomized trial, overall survival of nivolumab versus a single agent chemotherapy. All these patients had cisplatinum as their primary modality chemo as part of their treatment. And again, you see that the overall survival was about 8 months versus 5 months. So this is really a last resort kind of thing. This guy's lung nodules did come back positive. We had them biopsied by interventional radiology. And at this point in time, this guy still wants to get immunotherapy. I did try to tell him about being DNR, DNI, hospice care, because I don't think it's going to last past several months, but he chooses to do that. I always say, go ahead.
So thank you. This was an excellent case, and I think it was an excellent discussion. Yash, if you just bring up your slide. In the interest of time, we're just going to move out of respect for Yash.
Can you get out? Yep.
I'm out.
And the one thing I would say for the audience is, if you notice, none of us talked about surgery. Everybody talked about the day after surgery. What are you going to do? What's going to happen to this guy? What's the outcome? And this is really the story of hypopharynx and advanced disease. And that's what you're going to learn through your career. You can do these surgeries. This is not the big problem. It's just the decision making and what's going to happen to the patient afterward. Okay, Yash, the floor is yours.
Hey, Babak, I'm going to zip through this quick because at the end we have some technical considerations and it'll be fun to get everybody's opinion on it. And I want to thank Dr. Badi, who's our amazing fellow, for putting this together. So I want to present the case of a 69-year-old female with a 4-month history of progressive dysphagia that we see in the office. And when you see her in the office and scope her and do your speech language evaluation and all those things, you see a patient with a left vocal fold paralysis, and you are really unable to see exactly what is causing that. And you obtain a CT scan of the neck, which shows an infiltrative tumor in the left hypopharynx, or you don't really see anything in the larynx. And so we take this patient to endoscopy, and we take microlaryngoscopy, bronchoscopy, esophagoscopy, a full evaluation of the upper air digestive tract. And there's a lesion that basically coats the left piriform sinus. And so
is it an endophytic or exophytic lesion?
It is exophytic to some extent, but clearly infiltrative. So, not exactly one or the other.
Do you have clear margins of the tumor interface, or is it like kind of nebulous going all over?
The tumor margin is clear, but it is infiltrative. It's fixed to the larynx. And I'm going to move along a little bit. Obviously, we take biopsies of this tumor and obtain additional imaging. The microlaryngoscopy and biopsy shows the extent of the tumor. And when we biopsy it, this is the pathology. Shockingly, not everything that looks like squamous cell carcinoma is squamous cell carcinoma. There have been a number of times in my short career, I suppose, that I've seen atypical pathology. And so this is a tumor with a cribriform pattern that you can see infiltrating into muscle and fat. And so this is adenoid cystic carcinoma. Okay.
Okay.
The patient is presented at tumor board. Take it away, Babak.
Okay, adenoid cystic carcinoma, perfect case. Thank you for presenting it. So adenoid cystic carcinoma at minimum T3, because your cord is not working. We don't know how long this tumor has been there. The evil of all evils. All right, so Shahrukh, you're the expert.
So first of all, this is obviously not coming from Yash's group. Then those slides will be reread at my institution. Make sure it is adenoid cystic and not something else. So that's number one.
There are minor salivary glands in the hypopharynx.
So anyway, but if this is adenoid cystic cancer,
kidding aside, that's a great point. There is nothing wrong with the slide in rare pathology. Go ahead.
Yeah. So anyway, that's there, and then this guy sounded like Yash, did you say he had any metastatic disease already or no?
She no metastatic disease.
So in my hands with really a cord gone, I'm assuming you've already done a swallow test. Maybe there's some swallow issues, obviously. Then you really, in our hands, will be surgery up front, which would be, unfortunately, with her would be a total laryngopharyngectomy with a free flap. You might leave behind a strip of mucosa. You can do closed margins if you want and then radiate them afterwards. But by the time I'm done with these resections, the amount of strip that's left on the pharynx is so skinny, usually just easier to tube a forearm or an ART and be done with it. I guess you could make an argument separately. You could come in from the side and just take that piriform sinus out. But I think with one cord already out, you'd have to do at least a vertical laryngectomy, and I don't think she's going to have any functional swallowing. So I'd rather
swallowing function in the office was poor.
Yeah, so I would just clean it out, make it a safe airway, and move it along. And I'm assuming, again, other things we think about in this is how far they are from our center, who's going to manage them. There's all these resource issues we think about for patients coming away from rural areas where there may be no help, and we got to really make a safe airway.
So let me ask Dr. Harris, is there any role for primary radiotherapy-based treatment for adenoid cystic? Okay.
No.
And then Jeff has always been an advocate of further testing. Jeff, would you, if you send this for Foundation 1 and you do find a targetable mutation, what would you recommend?
Well, I have been very excited about the progress of molecular testing and fitting it into how we treat patients. It's certainly a very hot up and coming topic and gives us a lot of information. We have to be really careful about using it as a decision making for everything under the sun. In this case, as far as I know, we have a treatable, curable, resectable cancer of minor salivary gland origin. And whatever the foundation testing shows, That's where that excels best in disease where it's metastatic, it's spread out, where we're looking for agents that'll have effect. This is a case of a treatable, curable disease. In my estimation, there's no role for molecular testing at this point in the treatment paradigm because you could just do surgery, and I would favor adjuvant radiation and cure the patient. So that's how I feel about that. Now, yeah.
Quick,
How would you manage the
from,
necks?
Quick, 1 second. Quick poll from Riz and Mike. Just a quick yes, no. Surgery or non-surgery?
Surgery from my perspective. I mean, I think the minor salivary gland tumors, relatively radio-resistant. You know, I think that you're heading down surgical pathway for this case.
Mike?
Surgery.
Okay. All right.
For the trainees, adenoid cystic can occur in obviously salivary gland in funny places like the trachea, larynx, but it can also occur up in the skull base and nasopharynx. And sometimes there are considerations for symptomatic disease just being radiated. I've seen
Unresectable.
Yeah, unresectable disease. Perhaps you'd consider, if it's symptomatic, you would consider radiating it in the skull base, but that's all I've ever seen. Are there options for open or endoscopic resection?
Great question. Anybody would do this endoscopic? Speak your truth now. This is your last time.
No.
Okay.
Agreed. And for the trainees.
This is, adenoid cystic carcinoma, and also, to be honest with you, for everybody, not just trainees. I'm not that far out of the training. I think the adenoid cystic is one of those tumors that's extremely difficult. Do not underestimate the margins. It's difficult to get negative margins for this. And
there's
the last thing you want to do,
parapharynx.
exactly. And the last thing you want to do is with a patient with a already not working larynx. That means that this tumor has been there for 10 years and people missed it. And it's just a classic history. I actually reviewed quite a few lawsuits of delayed diagnosis for adenoid cystic of laryngopharynx. So this is, if this patient comes to you, do the safe thing, go big or go home.
Great. And how do we proceed with the laryngectomy? And do we do a neck dissection?
Okay, let's ask our panel, Dr. Aslam, how would you approach this case surgically, and would you do the neck?
I would, I think there's obvious risk of submucosal spread, like Dr. Patil was saying, PNI, LVI. So I think you have to treat this with pretty generous margins. I would enter from the contralateral pharyngotomy, get good visualization as you would do with the laryngectomy. I would not necessarily dissect the neck, to be honest. I don't know if there's a...
And what about the central compartment?
I think if I'm there, that would be included in my specimen, but I don't have any, I think this is such a rare disease. I think that from my perspective, if you're there, I would always address the central neck and total laryngectomy to begin with. So,
would you do it a neck?
Neck, yeah. I would, yeah, I mean, you're going to be right there. Instead of a narrow field laryngectomy, I'd clean out the neck at the same time. There are some reports or other adenoid cystic that shows that, removing the lymph nodes can have an impact and survival. We didn't used to do that when I was training. We'd leave the lymph nodes alone. But I think just part of the access, you're going to put a free flap up there. I think the lymph nodes are going to come out just part of the technical ease of putting your flaps in and stuff like that.
Mike, what would you do? Would you do the neck?
Yeah, I think by practice, I probably would. I mean, the data comparing, surgery with adjuvant therapy or just electively treating the neck with radiation when you're radiating the primary isn't that strong.
Not for adenoid
survival
cystic.
Benefit. Yeah, I think it's, I certainly would do the central neck just because as long as you can get the parathyroids out of the way, there's very little downside. I think when, this comes into play when you're doing salvage laryngeal surgery. I always used to do, necks, and I still do most of the time now, but with N0 before, N0 after treatment, it's a separate topic, but a similar discussion. You're weighing, the risks of carotid exposure and contamination with just the impulsive desire to remove the lymph nodes. And I think it's just not a trivial point because certainly a fistula, I probably would, but a fistula in a patient who's had a neck dissection is a bigger deal.
Let me ask Don real quick before we go. Don, how would you approach this in Miami? Would you do a neck for these cases for adenoid cystic?
I would 100% do the neck. And the reason is a minor salivary gland adenoid cystic of the tongue base has the highest incidence of regional mets of adenoid cystic. It's low, it's like 10%, but it's not zero. And I think there are not enough hypopharyngeal cases to really know, but those are, it's such that much more aggressive location for other mucosal lesions.
Yeah.
I would, but I'd do it for the reasons Sharup mentioned, which is I think I'd be doing a forearm, and I wouldn't spend this much time thinking about neck dissection if I'm getting vessels out. I would just do the neck.
The reason I
Jeff,
ask
you had
is,
a comment?
I'm sorry to interrupt. The reason I ask is the teaching in radiation has historically been to radiate the primary only. With adenoid cystic, it's the one primary histology that you routinely would not cover the neck, but recently, especially in high-grade adenoid cystics, especially in the aerodigestive tract lower than the sinuses, you really have a risk. So in this case, if the necks were dissected in negative, this is the only circumstance where I would radiate the primary and leave the necks alone.
I think that's a great comment. Okay.
With paraglottic space extension, the ipsilateral thyroid was removed, along with the ipsilateral cervical lymph nodes, and laryngopharyngoesophagectomy was performed. And this is the specimen. It's been bisected posteriorly, and you're looking into the larynx, but you see that it really was kind of a hypopharyngeal lesion, and it looks widely resected with clear margins. I just want to go over the resection because it'll be fun to listen to everybody talk about how to reconstruct the hypopharynx in this female. Are there options for primary closure or free tissue transfer?
Okay, let's ask the microsurgeon. Mike?
So this is just a laryngopharyngectomy, essentially, or did you
Yep.
take up the esophagus too?
There's a very thin strip at the end, and it would be very challenging to close on its own.
Yeah, so body habitus thin.
Thin but female.
Okay. I mean, I guess it would just depend on what the thigh looked like versus a forearm.
Okay.
Jejunum works well, but it requires an abdominal incision, and unless working with an additional team, so would probably do in a really thin person with pliable skin a thigh because I like the muscle. Otherwise, I would do a forearm.
Okay. Let's see, Shahrukh, what's your choice?
So obviously, like I said, these things end up with a circumferential defect. Otherwise, you're left behind with a little strip that doesn't do anything. So I take that strip down and do a circumferential, radial forearm, depending on the thigh size, ART. Although I really like radial forearms, I've always done them. They work out pretty well. I just make it a round circle and be done with it.
Okay.
Now, here's the interesting thing. I think that the next part you say is monitor paddle, so you can bring part of it out. But if you want to, I mean, I've buried my flaps as well, and they do fine. I think, especially if you have a wide bore radial artery flap, then they do okay. So you can do whatever you want. I do not use salivary bypass tubes or anything like that. I just freak out about it. I do design my width of the flap or the diameter to be at least 7 centimeters. So the width of it. So that's why the forearm size becomes very important.
Yeah.
And sometimes
I go 9.
I'm going over the radial aspect to harvest it because I'm trying to get once you circumference it out, and you do the pi d thing, and we measure this out and we do this whole mathematical thing. I think it gives them a nice big pharynx, basically.
Yeah. Okay.
Who would do a primary TEP?
So that's an excellent question. Riz, would you do a primary TEP?
In these particular cases, I always, if everything is favorable, I would try to do a primary TEP here.
Don, what's the philosophy in Miami? Do you guys do a primary TEP for these big resections? You're mute.
Not very often, but for certain patients who, really are desperate, I will bend the rules for them.
When the tracheoesophageal
and I do like
wall,
the forearm.
When the tracheoesophageal wall is widely separated because of a resection going low, sometimes it's hard to predict where that TEP is going to end up when they heal. So here's the resection done. There's a strip of pharynx. We preserved it. And I don't try to bring a little tab of forearm out. I put a little monitoring paddle in the proximal forearm, and I just stick it out in the neck like this. And then on day 3 or 4, I usually have a fistula drain that I begin to irrigate no matter what. And by day 5 or 6, if they don't taste it, I quit irrigating and pull all the drains out. I'll stop there.
Okay, very good. And I assume that you got negative margins. So would you recommend adjuvant treatment?
She did not have radiation therapy.
Dr. Harris, would you recommend adjuvant treatment?
Say that generally adenoid cystics recur in the sinuses. We always offer adjuvant treatment. Well, always.
So I agree.
An overreach. What's that?
You know, since I'm a memorial fellow, Spiro used to say, if adenoid cystic is a disease, that if the doctor or the patient survives long enough, the disease always comes back. And all of us have this mantra that T3 adenoid cystic in otherwise a healthy person that had a high life expectancy. And this is a larynx, radiation. It's not particularly morbid. It's not like you're doing the eye. I would personally, regardless of the margin, I would recommend adjuvant. But I'm interested to hear others. Shahrukh, what would you do? Would you recommend radiation? Adjuvant?
I actually believe in radiation with adenoid cystic. They can have microscopic disease. But again, I leave it up to our radiation guys. But in our tumor board, we'll probably end up discussing it and offering radiation therapy.
She was offered radiation, and she did not take it. And I followed this patient I followed her more than a decade.
That's awesome.
Jeff? Well, that's fantastic. Jeff, what would you recommend?
I would recommend radiation.
Mike?
I would recommend radiation as well.
Don?
Radiation.
Yeah, so the point for the audience is do not underestimate. Your surgery was excellent, but don't underestimate adenoid cystic. It's a terrible disease. Okay.
I just want to pull the crew for one change in variable. If this patient had presented with miliary metastases to the lung, highly suspicious for adenoid cystic, would you still have done the surgery?
Question.
Okay. Let's see.
Well, Bobby, what would you do? Let's go flip classroom.
Adenoid cystic is a slow-growing disease. The reason for her morbidity comes from the larynx, not from the lung. That's number one. Number two is in good hands like Yash's hand. You can do the surgery safely and get her off and give her more time. So in adenoid cystic, as long as and you can make it a little bit more complex. If you want, you can actually look at the pathology, your biopsy, to see what kind of adenoid cystic. If you have a really, really bad, rapidly progressive, that's different. But the majority, garden variety adenoid cystic, I would do the surgery. Yes.
Agreed.
Anybody disagree?
Surgery.
I don't disagree, but I would make the one point you presented miliary lung metastases. The younger patient who presents with liver mets and lung mets and bone mets and a primary tumor is a different adenoid cystic than what you've just described. And that's the patient I would be very thoughtful before offering a total laryngectomy, particularly since that's quite morbid. They don't have very good options no matter what, but there is this sort of bimodal distribution of adenoid cystics with they just don't often present with widely metastatic disease, and those that do don't have a long life expectancy.
And those of you who are interested in running, you probably remember the famous case of Gabriel Grunwald, the young professional athlete who had an adenoid cystic of the parotid and had multiple surgeries, had a liver metastasis, had a liver resection, continued as a professional athlete, and unfortunately succumbed to the disease last year or 2 years ago. So adenoid cystic is different, and I think Don's point is excellent, that you have to look at the disease, and there are diseases that are rapidly progressing, but other than that, you probably can do something for the patient. Okay, it's 8:05. Thank you all for joining us. I cannot thank Riz for arranging this excellent session and the excellent cases from Yash, Shahrukh, and participation of everybody. Dr. Harris, welcome. I hope we have you for the next sessions as well. And our resident experts, Dr. Michael Moore, Jeff Liu, and Dr. Donby. Have a great evening.
Everybody
We'll
stay
see you
safe.
in 2 weeks.
Happy New Year, everyone.
Fantastic
Stay safe.
session of complication. Happy New Year.
Thank you,
Bye,
guys.
everybody.
Thank you, Riz.
Thanks.
No problem. My pleasure. Thank you.